Good afternoon. Welcome to the MGMA November meeting, chapter meeting. We're excited to have everyone joining us. Hopefully your wait in our Zoom waiting room wasn't too bad. Definitely beautiful day and getting ready for the holidays. So hopefully everyone is excited about Thanksgiving. Before we officially get started with our great presentation today, I do want to make a few announcements. Number one, starting December 1st, you should start seeing or receiving an email from, could be a combination of the Tennessee MGMA as well as Mid-South MGMA about your renewal for dues for 2021. The exciting part of that is the board decided to discount membership for next year. It is predicated upon renewing by January the 31st. So you have until January 31st, 2021 to renew. But the board graciously extended a $150 discount to active membership. So that membership will only be $200. And that does still cover both the local chapter as well as the state TMGMA dues. And for affiliates, it's a $200 discount so that you will only pay that difference for your dues when you renew as well. So excited about that. Definitely it's been trying times for all of us. We're not, I'll say we haven't crossed the finish line yet. We're definitely eagerly anticipating when we can, I'll say, get through this, especially the ability to get back to the Chickasaw Country Club with our meetings, enjoy good food and fellowship, but hopefully that will be coming soon. Another thing, we are going to be sending out an email, basically a survey to everyone, asking for your input, support, or interest, I'll say, to participate on the board in any of our committees. We have had some changes in membership and on the board as well over the past year, and we are excited to get more people involved in the board activities. It's fun, it's exciting, and would definitely love to see more new people, new faces on the board. So definitely be on the lookout for that email and look forward to hearing from a lot of you guys to participate on the board. Third thing, we are going to have a December meeting, virtual meeting on December the 10th. That's Thursday, December 10th at 6 o'clock. This year, as we've done in many years past, we are supporting the Porter Leaf Toy Drive, and the December meeting will be the finale for that toy drive, as well as some business that we'll take care of. And we'll have a speaker from Porter Leaf talking about that organization. We are excited that the board has agreed to match up to $2,500 for donations from MGMA members and affiliates. So definitely be on the lookout for that email to participate in the Porter Leaf Toy Drive. And we're definitely excited for that organization. So without further ado, I am going to turn the meeting over to our sponsor for today, Clint Cummins, CEO for Memphis Medical Society, MedTemps. They are the sponsor for today's meeting, and I'll let Clint take over.
Thanks, Eric. We're presenting a little bit different angle today. Our foundation, which is something you don't hear a lot about from us, is a 501c3. One of the programs that we've recently launched through that foundation is a program called Thrive, which generally speaking is the platform we use to talk about physician well-being with our members. But the primary product out of that program is a hotline, and I want to talk to y'all a little bit about that. Before we start, I also want to point out Memphis Medical Society's board also voted to match those funds that Eric mentioned about the Porter Leaf Toy Drive. So we are going to definitely have a 3-to-1 match on your donation, and we might even actually have a 4-to-1 match. So you're going to get some emails with some more information about that, but I think it's going to be a great opportunity to showcase MGMA and be able to really, having a 3 or 4-to-1 match is not something you see every day. So hopefully we can give some good support to those kids at Porter Leaf. I'm going to share my screen And hopefully this all works the way it's supposed to. So our Thrive Wellbeing Initiative, as I mentioned, and Hotline is a program that we've had going for about 3 or 4 months now. We want to just continue to promote this, and that's why we were happy to pay that modest $500 fee to be a sponsor of today's meeting and to get to burn y'all's ears for about 3 or 4 minutes here and talk about the program a little bit. So, it begs the question, why? Why do we need a program like this? First of all, before COVID, physicians and a lot of you medical practice managers out there burdened with EHR frustrations. Running a medical practice can be a very stressful endeavor. I think we've all become more acutely aware of mental health challenges these days. And, that's the reason we're having the speaker that we're having today. Another reason, we wanted to put this out to our physician members is a lot of us already know physicians are bad at self-care. They're skeptical of EAPs that their employer may provide or other workplace offerings. They're worried about confidentiality. There's that, overtly type A confidence dynamic with physicians that makes them, think they can take care of their problems on their own. And we have a lot of data that refutes that basically. And we wanted to be able to provide a local offering here to get ahead of those issues before they get too bad. The antiquated impacts on licensure, physicians are slow to identify that they're having some mental health challenges. They're afraid it's going to have a negative impact on their licensure. The country and the state have been slow to update those rules around licensure, but it's happening and it's coming. And I think that's lending itself to this overall mental health conversation that we're having in the medical community. And if you really think about it, those of you that are familiar with medical schools and how they operate, when you go through medical school and residency, there's really no time for vulnerabilities. There's no time to be stressed. You're training and working your tail off, basically working, 80, 90-hour weeks and trying to take care of personal and family responsibilities. And again, that's another dynamic that's been slow to come around, but I think our training programs, particularly the one here in Memphis, are starting to be more acutely aware of these mental health challenges and are offering their own programs in addition to the one that we provide. COVID brought about a whole nother bag of stressors for physicians. Taking care of patients got more and more difficult, probably still is for a lot of you out there. Family support on the patient side. We've all heard stories of people who are in the hospital with COVID and their family members couldn't be around them because of fear of infection. That only creates more stress on the physician. A lot of physicians lean on those family members to be able to communicate, what's going on, and not only to the patient, but to the family as a whole. So a lot more stressors and challenges created there. And really, some of the data that I'm going to share very briefly shows that 3/4 of the physicians in Memphis are experiencing some form or some level of burnout. So I want to be able to provide this hotline to get ahead of that. Here's some quick burnout numbers on the national level. This is actually from this year. I believe it was pre-COVID, but as you can see, basically no matter what specialty you're in, you've got a significant number of physicians who are burned out. Here's some local data. We published a survey right at, I think about 2 months ago now, to our members. 82% of the people that responded said they were experiencing burnout. This is all physicians. 35% described the burnout level as moderate to severe, which is also kind of scary. About half the people that responded said COVID only increased the burnout that they were already experiencing. Another thing we were able to gather from the survey is, as I alluded to on the national slide, this spans all specialties, all hospitals, private practice, large practice, small practice, every age, every gender, every career stage. There's no specialty or practice dynamic that's immune to this issue. And the other thing that we saw is there's really not one single factor that everyone's dealing with or single source of the burnout. We saw everything from finances, pressure top down from the leadership, either pressure to perform as a leader yourself, or pressure from your leaders to do more, with most likely less. That leads to just a general overall performance anxiety. Everybody, I think, out there's dealing with some additional family stresses due to COVID. Again, that's not any different for physicians. And in some specialties, increased patient load due to COVID was also contributing to that burnout. So here it is. Here's what we proposed to offer and are offering. It's a Thrive hotline. All the information is on our homepage right in the center, mdmemphis.org. This is how they can access. You can actually access it without going to the website. The number on the screen there, 286-3110, can be texted or called, and they'll be taken care of. We decided to launch 100% telehealth after researching some in-person options. Combination of a lack of in-person appointments and COVID basically put us in the corner of, we got to launch, and we're going to do it 100% telehealth for now. When things hopefully get back to normal, we'll take a look back at some in-person options. If you do know some psychologists with in-person availability, please give me a call, because we'd love to try to set them up to be able to see our physicians. And that's one thing, that's not really spelled out on the slides, is that, the idea is that these men and women who call the hotline are going to see a psychologist, that they're going to see one, hopefully fairly quickly, because we're offering the telehealth option. It's 100% confidential. There's only one person on the other end of that line that knows who's calling. And that person signed a confidentiality agreement, and no one else involved with our organization will see it. So after that, only the psychologist sees the patient information, so you can assure confidentiality. Memphis Medical Foundation actually pays for the appointments. That's something we found in our data, that it was either the next thing on a line of excuses. It's the reason a physician didn't want to seek care, or just generally, didn't want to shell out the money to have an appointment. So we're paying for up to the first 6 appointments for folks to experience. If there's any real complex cases, this is really for other clinicians out there. If it's really bad, we can refer them to the Tennessee Medical Foundation if we get to that point. But the idea is for this hotline to circumvent that process, which can sometimes come with some punitive damages, but they also offer a higher level of care that preempts those punitive measures as well. So we want people to feel comfortable that if symptoms are severe, we have some other options from where we can send people. And then just the last thing I'll say is, if you look at this from a utilization standpoint, your utilization rate is not going to be very high. 2 to 3% is what you're looking at. But when you look at an organization with 2,300 members and think about how many physicians you're helping, that's a big and significant number. And our about 3 to 4 month in data already shows that we're right at that rate. So we're getting pretty regular, but not too many calls into the hotline. Be happy to take questions offline. I want to make sure we get to our presenter and give her plenty of time, but everybody knows how to get in touch with me if you've got questions. All the hotline information is on our website, as we said. Thanks, Eric.
Thank you, Clint. Great program, and timing obviously couldn't be any better than now. So without further ado, I'll introduce Adriana Smith to introduce our speaker for today. Thank you.
Hi, everybody, and thank you, Clint. That is great information, and it was news to me, especially the burnout rate amongst our providers, just making sure we're taking care of them and taking care of ourselves, because this is a hard time for everyone. I am happy to introduce Becky Stoll, who's going to talk us through some mental health awareness and just how to combat things going on in this pandemic. Becky Stoll is responsible for, well, first off, she's the Vice President of the Crisis and Disaster Management at Centerstone. She's responsible for the operation of Centerstone's Crisis Call Center, mobile crisis outreach teams, suicide prevention efforts, and disaster mental health management services. She holds a master's degree in social work from the University of Tennessee and is a licensed clinical social worker. She has over 30 years of national and international behavioral health experience and is a recognized leader in this area of crisis services, disaster mental health, and suicide prevention. She's spoken at the White House. She's been quoted in Time Magazine, USA Today, and the Washington Post, just to name a few different areas. She serves on the board of directors for the American Association of Suicidology as the Crisis Service Division Chair, the National Suicide Prevention Lifeline Steering Committee, and Tennessee Suicide Prevention Network's governor-appointed advisory board. Becky, we're happy to have you. Thank you for being here today.
Yeah, so excited to see you guys virtually. So let me share my screen. It says the host disabled participant screen sharing.
Try one more time. It should take care of you.
All right, there we go. So I'm gonna start this one. And trying to see where it'll let me show it in a slide presentation.
If you go to slideshow at the top, oops,
Hang on.
you should be able to reshare, but when you go to slideshow at the top, you should be able to click from beginning.
Okay, I'm gonna go back to it. Yeah, there we go. All right. So can you guys see that?
I think you need to hit share screen again. We lost the share there for a second.
All right. Well, it is not showing that one. All right, hang on. There we go. And how about that?
Looks great now.
Great. So I have a couple of slide decks I wanted to share with you all and talk a little bit just about some of the work that's going on in the industry around safer suicide care, including that of our workforce. And it's interesting just to hear that information that was provided and what you guys are doing to really get out in front of some of this, because it's really quite a big issue across the country. Just a little bit about Centerstone. We're a very large behavioral health provider. You can see there, you know, what we have. We have services in a multi-state footprint. We have a, a division of military services. We have a research institute, a foundation. So we're a very large national behavioral health and integrated health provider. So kind of just to calibrate us, you know, the suicide rates in the US are definitely something that have been on the rise really for over a decade now. And regardless of what we have seemed to be able to throw at it, those rates continue to kind of rise. So we have a lot of work ahead of us in this state. You know, I've been asked a lot, I've done a lot of media interviews, and a lot of what we've been asked is, you know, what about COVID and what's happening with COVID? And is COVID, you know, increasing the rates of suicide? And up until August the 14th, you know, my response and others of my colleagues have been, we don't know. We can speculate. Suicide rates in general during times of disaster usually seem to go down. People kind of hunker down and get to operational mode. But what we see in pandemics, you know, we all we have is something from, you know, back a really long time ago. But on August the 14th, the CDC put out a report in their morbidity and mortality report. And what it said, or some of these points I'm about to make with you, it looks like at this point, the pandemic's associated with some increased mental health issues for folks, not only related to COVID itself, but related to some of these mitigation activities that people have been asked to do around distancing and not being able to be out and about like we normally would be. So you can see from this window of time in April to June, and they looked back at a comparison of last year, that the depression and anxiety that individuals are feeling in the US are really starting to rise. And so what does that really look like? And this is some of the details out of that. And what that report said was when they looked at this comparison to a year ago, you can see the statistics here. A lot of people are having mental health conditions, including this anxiety, depression, trauma. We're seeing increased rates of suicide or substance use. And then not surprisingly, but a little alarmingly, almost 11% of individuals in the past 30 days had not only considered suicide, but had seriously considered suicide. So that was troubling. What was more troubling is this box over to the left. There were 4 distinct groups of individuals in this surveying that they did that had cause for alarm because their rates of seriously considering suicide in the past 30 days were much higher than this almost 11%. And you can see those groups over here. It was individuals ages 18 to 24. It was some minorities, which were Hispanic and Black Americans. The highest was unpaid caregivers. And then behind that was essential workers, which would include your population, who came in at almost 22%. Had seriously considered taking their lives in the past 30 days. So these are individuals that are of really even higher concern. So that's kind of the state of the union with how COVID is starting to play this impact. There's been a real push since 2012 when the second national strategy for suicide prevention came out with its plan under the Surgeon General. And it really said, we have to start treating the whole person. And it put, for the first time, language in the national strategy that talked about systems of care, the healthcare system and the behavioral healthcare system playing a role in suicide prevention. And you see where those fell out. They're in goals 8 and 9 of that national strategy. It was a little surprising that the strategy that was written in 1999 never mentioned healthcare playing any kind of role in trying to reduce the suicide deaths. And we saw in 2012 that was corrected and they were included. There is an initiative across the US and abroad. I would really say it's kind of taken hold across the world, that we shoot for and have an audacious goal that we're going to aim for no suicide deaths in our system, knowing that that's the most appropriate goal. That, having a 5% reduction or having no more than 10 suicides or things like that just feel incredibly inappropriate. So that we take the stance with this framework that suicide deaths of people in care are preventable, and that we should be leveraging entire systems of care to try to work on this. Where that really hits the road in the physical health space is that most people who die by suicide are coming to see physical health much, much, much higher rates than they are behavioral health. So we need you. I spoke at a physicians conference down in Charleston, South Carolina last year, and there were hundreds of them, and this was going to be kind of some new information for them. And I knew my anxiety about speaking to them about their role in suicide prevention was high when I had a dream the night before I was going to present And in that dream, I showed up to speak, and there was nobody in the room. It was completely empty. And so I was eating a ham sandwich, and a cleaning lady came in and goes, "Well, get on with it." So I got up on the stage, and all of a sudden there were all of these healthcare providers in the audience. And I thought, good, they're sitting and they're listening and they're ready to play their role. And then when the first person got up to ask me a question, they spoke German. And I don't speak German. So I knew my anxiety was high, but they were really hungry for this information. Once I was speaking with them about how we need each other, and we need to definitely left hand and right hand this problem if we're going to try to make any headway. You can see these statistics are pretty startling, that so many people are visiting the healthcare system in the year before their death. Even half within 4 weeks of their suicide death, they're coming to see physical health. They're not coming to see behavioral health. So we have that real opportunity to catch people through screening efforts. And then once we know they're positive on a screen, that we can push them into some kind of referral pipeline into the behavioral health system. We also know that physical health conditions increase risk, some of them for suicide. And a really good colleague, friend of mine, Dr. Brian Amadani, who works at the Henry Ford Health System in Detroit, did a study. And they looked at physical health conditions related to suicide risk. And you can see kind of some of this background that Brian put together. And he says, if we only target suicide prevention efforts in the physical health space, we're really missing the boat. And that we have to make identification through screening efforts a real priority. And what he saw, they went back and looked at some data, and they reviewed 19 physical health conditions that were associated with suicide. And the ones that I put bolded here had, enormous risk, more than 2 times, and in some cases multiple risks. And if people had more than one physical condition, their rates of suicide were even higher than if they just had one. But these were the 15 or so conditions that are associated with suicide risk. And the ones that are highlighted had at least a 2-time or higher. So just trying to make sure that physical health folks are aware of these. And some of your colleagues, some of your physicians and other medical personnel are surely not immune to some of these conditions, like back pain or migraines or sleep disorders or bouts of, different types of cancers. So what Brian learned through this is that there really are some commonly diagnosed medical conditions that have an associated with suicide risk. The 3 biggies were back pain and sleep disorder and traumatic brain injury. The traumatic brain injury was particularly troublesome because it had a 9-time risk higher than the general population. So it was definitely something that they felt like needed to be targeted. So all of these efforts and all of the work that needs to be done around suicide prevention has got to occur in both health and behavioral health. We have to work in tandem and both know, what our role is going to be and how we're going to interface. So what can that really look like in the physical health space? You see these ideas here that we have seen really very impactful. The biggest being that routine screening occurs at healthcare visits. I know when I go to a medical provider, they're going to take my temperature, take my blood pressure, and weigh me. And then some of them will put the pulse ox on. How can we make giving a screening that can be something as simple as 3 questions off of the PHQ-9? How do we do that so that we're identifying behavioral health, serious issues like suicide at that point of contact? And then what does the pipeline look like to get them care? You know, is it are you a practice that's so big and so busy you could employ an on-site mental health, liaison or something like that? Or do you have a relationship, a solid relationship so that you're creating a tube that you can, send people into, that they're going to get good care, and that you're going to be called, and that there's going to be real, true collaboration. That takes work. That doesn't, just happen by happenstance, but really how you can do that. Telehealth was spoken about by Clint earlier, is a wonderful way. Some physical health clinics have set up telehealth services with outpatient providers so that the patient doesn't even have to call and make an appointment later. You can plop them down in your space with a screen, and a telehealth visit can occur that way. And some of this, easily can be built into electronic health systems so that a lot of the stuff can be automated, and data can be extracted to see and engage how you're doing on some of these outcomes. So I'll hold the Q&A on this one real quick, and then I will switch to, so that's kind of the state of the union in that space. But let's talk specifically about providers and your folks, and how we can make sure people get some of the stuff that they need. And I've done a few of these recently. It was funny when I was asked to do this, I already had these slides set up, because I've actually been asked a few times across the country lately to talk about mental health wellness for staff, and particularly folks in the healthcare space. So let's talk a little bit about that. First thing we want to do is try to focus, upstream on prevention. So if there's ways to get ahead of this, and not wait till people are in the water flailing around and drowning, and we're trying to, initiate life-saving measures, or there are things we can do upstream that they don't end up in the water flailing around. Some of the things I've seen helpful, and I'm starting out light on some of this, but we have seen it be helpful, is focusing on the person's own wellness. What kind of paid time off and observed holidays, do you have? And are people encouraged to take their time off, or is that frowned upon? Does your leadership model taking time off, or are they known for never taking time off? And, that would be viewed negatively if you routinely try to take your time off. What kind of resources can you provide in your benefit packages? Around, things like gym memberships, and we have Blue Cross and Blue Shield. I get all kinds of deals and things like that. I recently bought the brand new Apple Watch, and it was considered equipment, where we get 50% off of our equipment. So I found an Apple Watch that was already on sale by like $100 or $200. And then I could buy it and turn my receipt in, and then get 50% of that back. So I got an Apple Watch for really, pennies, because I have a generous gym membership wellness equipment reimbursement that we're allowed. We do have access, and a lot of places do, to EAP. And I heard, Clint's right. A lot of people don't want to call the EAP because they don't know what that's going to mean, who's going to know. I really encourage, if your organization, your specific company uses an EAP, and you all are a specialized industry, which you are, what I have seen helpful, and I've helped set up here, where in the space I'm in, is find a provider or two or three or five that you can work with collaboratively to teach them about your culture. So I've helped do that with fire services and law enforcement officers. And I do, Centerstone does quite a bit of work in professional sports. So I've done that with some of the professional sport teams. Like, you want a provider that's not just, kind of a generic provider, but if it's a specialized industry like the medical field is, if you can get providers that you can offer some special training for and some prep for, so that they understand the culture and the language and the special nuances and stress, then you kind of have your little group of providers, and you're not just referring to the EAP, but you're referring to EAP using this special group of kind of handpicked high caliber clinicians who know that space and can do that. And the more you refer to them, the better they are at understanding this special kind of niche population. Are there other kind of life benefits that you can offer that are helpful? You know, and when we were in person, once a week, or not once a week, but every day there was a caterer that came in. So you could go downstairs and get really good food for not very much money. And it was kind of a win-win for this caterer. We had dry cleaning that could be picked up. So, you know, you have to, it's a little bit different with COVID, but we're not going to be in this situation forever. And so what other kind of, what can you do that helps the people that work for and with you, just to be able to manage their life and make their lives less stressful? On the professional side, you know, do people have opportunity to weekly or monthly decompress? I've seen emergency room departments do a really good job of this, where they offer time. It's kind of just a round robin, you know, gripe session, vent session, just to allow groups of people doing the same kind of jobs to come together and routinely let some of that steam off. I think that would be incredibly important during the COVID pandemic, that people just have an opportunity to talk about how stressful this is, how hard this is, for all the reasons that we know. Are all of the resources you offer to people in one good landing spot? Or do I need to, like, is it hard for me to access these things that you all may offer? Because you want to make it kind of one-stop shop. I want to know how to get in touch with an EAP. I want to know if we have decompressing sessions, when they are, and how I can quickly get to those. Training, you know, letting people have some wellness training and understand what are some of the things, the activities they could be doing to take care of themselves. Because you guys know, sometimes when you get busy and you're working so hard, all of those kind of self-care things go out the window. And even though you know you should be doing them, you don't. And so it's a good thing. I would say when we're in not in a pandemic, it's good to foster a fun environment. So do people enjoy working there? Is their birthday recognized? Is their anniversary recognized? Are there, you know, activities that make it interesting to be an employee of who you know, work with and work for? And also, you know, we try to give people opportunities to do community service that they like, and give people a day to go clean out the local animal shelter or paint an elderly person's fence or whatever it is. But giving back to the community is good. I just kind of screen grab some of this stuff because this is definitely the kind of thing I see. I run a very large crisis call center. We man a lot of different lines, and the supervisor in that program is very, very, very purposeful about people's birthdays and their anniversaries and Christmas. And they have luau's up there sometimes. They have a foosball table. There's a foosball tournament every year. Excuse me, which I don't enter because I'm a terrible foosball player. But they have a lot of fun up there, and the staff know that. That supervisor in that program also does a really good job. When she hires someone, she has them fill out a survey, and it's unlike any survey you would think you would fill out as a new hire. But she's like, what's your favorite fast food restaurant? You know, are you vegetarian or you're not? You know, what's your favorite TV show? What do you like to do? And she's trying to just get a fun profile of them. So then if she wants to go buy them a gift card because they had a really rough shift or they really helped someone who was suicidal in the crisis call center, she knows they love Chick-fil-A and she's going to go buy them a, $15 Chick-fil-A gift card. But she makes them very tailored to the person, so that when she's trying to do things like that, it's something they really like. We have one big, huge, burly guy that works for us, and he likes to take baths, she told me. So if she wants to get him something, she'll buy him like a bath bomb or some bath salts or something. He is not someone you ever would peg for that, but she can make it personal for him when she does stuff like that. So when we're talking about suicide prevention and these professions, it's really important, for an organization like yours to know what the trends in your profession are. And you could see those burnout rates that Clint showed. What are the rates of suicide? We know in physicians they can be higher, but know that trend if you have nursing staff that work for you, if you are an ER physician versus a urology physician, what are some of the specific data related to those professions, and then educate everyone and know what those trends are, and then offer education opportunities to your population, and let them know, what are some of the things people can do around help-seeking behavior, and they should know. I had an attorney who was a colleague's cousin or something reach out to me not too long ago. The guy was not doing well, having a really hard time, and he wanted to go see a counselor, and he had called it was either the EAP or the insurance company, and they had emailed him a list of providers that they covered. And it was about 9 pages long, and it was single spaced, and it was just based on his zip code. And he had no idea what the letters behind their name meant. Some of them he could tell were male versus female. And this gentleman was in tears, literally crying with me going, I'm trying to get help, and he had called the first 2 numbers and they weren't taking new patients. So making help easy and not just, here's a list of people and good luck with that. If you have suspicion that you all might have someone, that's you're concerned about, you're going to get that from a variety of ways. Sometimes it's self-disclosure, or people that work with them, supervisors and others have some suspicion that it's not going well. Or you might see some social media post. You really have to have some processes in place where you're going to approach that person and see what you think is going on with them and talk to them. I have had this happen to me recently. We had an employee that had made some social media posts and sent some emails on a work email that really indicated that maybe this person was not doing well. And we were able to reach out to that person via their supervisor and just have a conversation and say, hey, we're a little concerned about you, and here's why, and here's what we have seen. If you have a suicide death, we know that doing good post-vention work is prevention, because of all the folks that have been left, in the aftermath of that. You have that person's family members, you have that person's who's died's patient. Again, I've had that happen to me. My primary care physician several years ago took her own life after a diagnosis of a medical condition that was not going to be a positive experience for her in terms of what she had been diagnosed with. And that was, I had seen her for probably the better part of 20 years and didn't know she had died until I went in for an appointment. So, I had experienced that as a survivor. And then you have that person's colleagues. So you kind of have these little buckets of people that you do need to be very cognizant of, that you make sure you're reaching out to them. And when it's the colleagues, we need to communicate with individuals around this in a really positive way so that people find out the same information at the same time. I went to a company once where a staff member had taken their own life, and they just put kind of a note on the door that said Joe died. It was really very insensitive. I went to another company where an employee had died of suicide, and they were a call center, and they sent out an instant message that popped up in the corner of the screen that kind of just went, "Hey, Joe died." Very insensitive, and was devastating to that person's, the person who had died's colleagues. So we need to make sure we communicate to them and then provide support, sometimes an individual level support, and sometimes that's group support, but just to make sure that people are getting what they need, because you don't know what's going on with the person who's been left behind and what this might do to trigger them. You can make those kind of reach outs voluntary. You can make them mandatory. You just have to decide in your system if you want to see if that's going to be something that you feel like should be mandated or not. And then if you have anyone you feel like is at high risk, you need to monitor them and, check in on them and make sure that you're kind of keeping an eye on the people that you feel like might be at high risk. Sometimes people, you all might, as an organization, want to set up a response team who can go if a practice had something and you have that, or, you can contract or have on tap somebody that might come in and be able to help you to get people aid. And then you also probably need to decide if you're going to just let people kind of self-refer that they need help if you've had a death in your practice, or if you're going to do active outreach to individuals and say, hey, we want to make sure you're doing okay. I recommend the active, but in some systems they prefer to do the self-referral. So I will stop there. That was a lot of information and a couple of different slide decks. And we'll just stop to see if anybody has a question.
I don't have a question, Becky, but an observation. I think it was interesting to hear you say a lot of this is kind of built in-house naturally by the team. We've seen that. The hospitals seem to be working on that, some more than others. And we're working with some of them behind the scenes to sort of enhance or tailor what they do. Do you have any advice? I guess this is a question now. Do you have any advice when people run up against roadblocks around costs? Because a lot of times to, start some of these internal programs, you are going to encounter some costs. So have you had any experience with that?
Yeah, I mean, I think it depends on what you want to, really get done. So I think on the staff side, to reach out to, some of it just takes time. So reaching out and getting a few clinicians that you say, hey, we'd like to refer to you when we have someone, and let us kind of teach you about our industry. Some of that kind of stuff doesn't, have high cost to it. Educating people and getting folks to come in and do training with them, shouldn't have high cost to it. Where I think you can start seeing cost on some of the, like the patient side, if you wanted to bring in mental health resources into your location, that's going to have a cost. I don't, to screen for suicide at all medical visits, you can bill for that. I'm doing a pilot now with a bunch of pediatric practices, and we're looking at that. They've added in doing a 3-question screening for suicide, and they're able to bill for that. And we developed a pipeline for them that if they have a positive screen, here's what's going to happen. And so that's actually brought some revenue in for them as opposed to the cost. I think you can surely do a lot of these things and not have to put big price tags on them. I haven't seen suicide prevention efforts really require a massive amount of money. Sometimes it's just awareness and tweaking and kind of leveraging, community resources. Now look at Eric, your question to an actor may realize they're struggling. My sense is if when you feel like people are struggling with depression and or suicide, is letting, active reach out to let people know that you care about them and that you're there, and that if they need anything, and even pointing out what it is that makes you think that, I see that you're staring off the space, or that you're crying, or, whatever it is that's caused you to feel like they're struggling. I think when you notice that observation to them and say, if you need anything, I'm here. I'm glad to be in the boat with you. That none of this would scare me. And if we need to get you some assistance, I'm glad to help facilitate that. That's what I've seen. Just like if you guys are sitting here looking at me now and I started sweating profusely and saying my left arm was hurting and I felt like an elephant was sitting on my chest and I felt really dizzy, I don't think any of you all would ignore that. You'd kind of be like, are you okay? Like, you look like you're sweating, and so I think it's just some of that kind of paradigm shift to being able to do some of that stuff on the mental health side. And yeah, I'm glad to send you my PowerPoints. I'll send them to Adriana, and then she can push those out if that works. And you can go read Brian Amadani's. You guys would probably be super interested in what he published on that, because I just gave you a little snapshot. But it was really interesting when they looked at physical health and suicide deaths. They looked at a massive amount of records and came up with that.
Are there any other questions for Becky? Becky, again, thank you for your presentation. I think any more, appreciate all the information from you and Clint today.
I have a quick question.
Sure.
Yeah.
Sorry. Quick question. I guess maybe it's not that quick. I know right now that we already feel like children are at risk, and teenagers, and they have been, I feel like, really impacted severely by the pandemic because they've missed a lot of school in the spring, and now some school systems and schools are going to be going back virtual learning again. What are some things that we can do to try to help kids through this time and help their mental health?
I think it's very similar to, I think, what we do with others, but I think talking about it and being very open and candid about, this is a tough time right now, and we are not being able to be social like we normally like to, and you can't go to school, even though kids don't want to go to school. When you can't go to school, you want to be at school and be, well, a lot of it's more the social aspects. And I think for some kids, it's academics. If you're a junior, like I have a neighbor whose daughter's a junior, and she's like, it's just or a senior, and they don't get to have proms and things like. I have a almost 22-year-old who is a senior in nursing school at Belmont University here in Nashville. They're about to go over the edge because, that fall semester before you graduate in May has been incredibly difficult, and it all went virtual. Nursing school is not really made for virtual, but having conversations with them about, this is tough. What are some of the best ways you and we together, whether you're the provider or it's the family, how can we navigate all of this? And then touch in about it much more frequently than we probably are. Too, they're online a lot more now, and we've, oh, they don't need to be online. Well, they are now online a lot. I worry about just what that lack of socialization is doing, maybe some enhanced time for bullying to be occurring, because they are online in harder ways. And so that's kind of my sense of it. I think we have to talk about it much more and touch base about it, and not really kind of one or done that, and know if a kid's having a hard time, what we're going to do about that.
Thank you, Becky. Any other questions from our audience? If not, again, great presentation today, Becky. Appreciate the information. We'll definitely get the slides out to everyone. They will be on our website in the days ahead. And so if you ever have questions for Becky or about the Thrive program, don't hesitate to contact us or Clint for that information. If no other information, news, or announcements, again, be on the lookout for your renewals coming December 1st and thereafter. We hope to see a lot of you at our December 10th meeting and look forward to supporting the Quarterly Toy Drive during that time. So again, thank you. Have a great weekend and great Thanksgiving coming up. Thank you all.